If you see someone who's got a raised cortisol evenly across 24 hours, I tend to think these days, well, that person is very on edge. They're what I call neurologically upregulated, and they're unlikely to be functioning optimally, particularly if it's very high. And if it's a bit high, it's not a problem. If I see spikes, then depending on what I know about what was going on at the time, I would say that they might be very reactive. So these are the people who, these are the children who might well be more prone to meltdowns, for example, because they spike under stress very easily.
Welcome to All Aboard, where we help parents navigate the ADHD journey. Whether you're at the beginning of this journey asking what now, or you've trodden this path for a while and are wondering what's next, All Aboard ADHD is here for you. We will bring you key information from expert interviews, inspiring special guest stories, and parents sharing their real life lived experience to help you feel less alone. I'm Claire, and today we'll be talking about integrative psychiatry and holistic ADHD treatment with our expert guest, Dr. Richard Fry. Dr. Richard is a consultant integrative child psychiatrist practicing in the private sector after many years leading services in the NHS. In the last 15 years, Dr. Richard has moved from purely mainstream and conventional approaches to a more holistic view of brain and emotional health. He now practices in an integrative fashion, trying to consider the drivers of ADHD presentations and how to address them. His aim is to minimise the exclusive use of medications and to optimise their effects where used. Metabolic and genetic health, along with individual character, are key to Dr. Richard's thinking. He places great emphasis on working in collaboration with colleagues skilled in physical medicine, as well as those with psychological expertise. He also draws on his trainings in many modalities of psychological therapies and works with a hand-selected team of associates. Welcome aboard, Richard.
Hello.
Thank you so much for joining us today. So I thought we could begin this chat by asking the question, because for a lot of people listening may never have heard the term before. So what is integrative psychiatry, and also what first drew you to working this way?
Integrative psychiatry is, I think, an attempt to get beyond just looking at psychological symptoms and look at the wider picture. So for me, that involves taking in metabolic, physical, body stuff, and also thinking about influences from the environment like lifestyle and social pressures and all of the way that somebody lives. It's a bit vague. Sometimes get confused with functional medical approaches, which is another slightly blurry area, but basically it's the updated term for holistic, which means looking at the whole person rather than just a bit of them.
Okay, so that's a really important term, isn't it? Whole person. And I'll come back to that in a minute. But if we just, on the context of how integrative psychiatry works, how is that approach different from perhaps more conventional child psychiatry approaches?
Well, I mean, I can only speak from my own perspective, because I think the people who do integrative psychiatry and functional medicine often come to that point from a lot of different directions. And my direction was sitting in a GP surgery for many years, being a GP on and off between doing psychiatry. And I just thought this is very odd, because on Tuesdays and Thursdays, I see people in a GP surgery and I deal with physical complaints that they'll bring in. And on Mondays, Wednesdays and Fridays, I only deal with their brains. And this doesn't seem terribly sensible. There must be a way of thinking about this in a more integrated way. And so I found that in the realm of integrative psychiatry and functional medicine, often people have a couple of things they're trying to bring together, particularly in integrative psychiatry, it's physical medicine and psychological medicine.
It's a real joined up approach, actually, isn't it, when you describe it that way? It makes complete sense. So when you talk about the whole person, as you mentioned before, and you're seeing the kind of child first, I guess, in that sense, versus the diagnosis, what does that mean in practice?
It means that I do a rather old-fashioned thing, which is take a very long history. And I don't do it in a sort of protocol fashion. So you can go to lots of places these days and they will bang you through a protocol of questions and give you a diagnosis of something at the end of it. And to me, that's terribly unhelpful. I'm not saying that the diagnoses are wrong. I'm just saying maybe they haven't thought about the wider picture. So when I was training in medicine, told to listen to the patient and try and make sense of what they're telling us. So I'm not saying that conventional child psychiatrists don't do that. We're all trained to do that. And child psychiatry is probably better at that than many areas of medicine, because you have to think about the context that the child is in, i.e. the family, the school, etc. So we're better at thinking about the environment generally. And I suppose for me, it's just an extension of that to the next level of thinking about everything else. I answered your question. I've forgotten what the question was now. Sorry.
No, absolutely. It was about what that means, the whole person element of it. And you use the term like an old-fashioned approach. So why is that, to use the old-fashioned term for it, as you said at the beginning, the kind of holistic approach, so important, do you think, particularly with children?
Oh, because children are just, compared to adults, they're relatively straightforward because they haven't got all that sort of mess of life mixed into them yet. But why is that important? Because I think this is where it's really relevant to ADHD, actually, which is why I think it's a good idea to talk about it here. I think it's because just thinking about a psychiatric or psychological label doesn't really capture the essence of what a child might be struggling with. And there are lots of things that are impinging on children that need to be thought about in relation to how they present with emotional or other related symptoms. Because emotional presentations or psychological presentations are manifestations at the end point of a lot of things.
So those manifestations, those other elements that are impinging on it, and I think you used the word context earlier, I'm wondering how those everyday context, everyday factors that make up a child's life, so whether that's things like sleep or diet, you mentioned kind of school there, how can all of those things influence a child's ADHD symptoms?
Okay, so we're diving in the deep end. So first of all, we have to have a small detour into ADHD and what it means to me and to some other people, I think, which is increasingly little. So for me, ADHD is not a particularly useful diagnostic category, just like autism isn't a particularly useful diagnostic category. I'm more interested in why someone might not be able to concentrate or is impulsive or acts as if driven by a motor in the classic terms, or is disorganized or can't do certain tasks or remember a list of things more than the first one on the list. I want to know why that is the case, rather than saying, oh, yes, you've got those 6 symptoms, you fit into the diagnostic category called ADHD as decided by the DSM committee in America. Here's some stimulants, goodbye. So for me, why is that? So it then becomes easy, I think, to see why I might want to know more about what are the things in that kid's life and that's going on around that child and in that family and in that context that might be driving those difficulties. Now, one of the things I struggle with on a daily basis is that there is no doubt that a lot of children and adults, increasingly we realize, but a lot of children present in similar ways with similar buckets of symptoms. And there is therefore a temptation to label that bucket ADHD and get on with it in the conventional way. And very often that's really a really good way of dealing with it. But quite a lot of the time it's not enough. And you need to do a bit more, I think, which is what I'm trying to do, thinking around the edges or alongside, if you like.
Yeah, I think you're right, actually. It's often not enough. So when you are thinking around the edges, as you describe it, what are those edges? What are those factors?
Well, that's the things you mentioned before. Are there physical, metabolic contributory factors? How much do genetics drive that? How much does diet contribute? How much is lifestyle in terms of sleep, interactions with the peers? And that could be related to neurodiversity. I'll do a small detour there in a minute, if you don't mind. And so we need to know and understand more about those other factors. So a child that isn't sleeping isn't really going to be able to concentrate, are they? Let's face it. A child that's knackered is not going to have a brain that works very well. So what might be contributing to that? Is social media a factor? Is bullying an issue? Are family constraints and context and dynamics contributing? Or do they have a raised cortisol level because they've got some intrinsic metabolic thing going on that drives cortisol and adrenaline and keeps them awake late? So that's just one example.
I think the nervous system stuff is really interesting. Like you mentioned cortisol and things there, and I'll come back to that. But you also touched on diet, and I just wanted to pick up on that because you wrote the foreword in Lucinda Miller's Brain Brilliance book, and Lucinda very kindly being a guest on the podcast before we did an episode on nutrition and the ADHD brain. And in your foreword, you talk about the problem caused by lack of micronutrients. And the quote is from yourself, is consumption of ultra-processed foods and our increasingly challenging environment interacting with our genes is part of the problem. So what does that mean for our children's diet and their guts and their brains? And then as an addition to that, what are the micronutrients that you're talking about, I guess, that you commonly see lacking in your practice?
If there was an easy answer to that, I will give it to you, promise. But that's why it's tricky. So there are some basic things that Lucinda's book that you've mentioned covers extremely well and far better than I could with all the evidence for it. And that's the difference, I would say, of Lucinda Miller and other practitioners in this area. Lucinda is extremely evidence-driven and very careful about that, which is, I think, why she and I get on so well, because I try to practice from a scientific basis, albeit that the science is inadequate and extremely patchy in lots of areas. And I could talk to you about research methodology until the cows come home and why there are problems with that, but I won't because it's too boring and a bit cliquey. So micronutrients are the stuff that we don't think about in food because we're taught to think about protein, fat, carbs, and sugar, and that's it. And actually, those are really relatively unimportant. Obviously, you need those things to make your body work and your brain work, but it's the other stuff around the edges. So magnesium, calcium, sodium, potassium. I'm reading them off a list because I've got it next to me because I knew I'd forget them. Manganese, zinc, chromium, vanadium, molybdenum, iodine, lithium, all those kinds of things can be really important. Now, you don't need usually to worry about all those things because they're there in our diets and we eat them all every day. But as our diet habits shrink and our sources of food have become more and more factory and manufactured driven, those things are less prevalent than they were. So the bottom line of all this, after years of sort of thinking and doing this, is it goes back to what my mum used to say to me, which is eat a varied and healthy diet, So eat lots of different things, which is why the eat the rainbow type thing is a really good one. The Mediterranean diet is a really good one. These are about variety and freshness. Now, variety and freshness are really hard to do in the modern world, but you can. I was thinking about this morning and I was thinking, I must ask Claire, do you have a garden?
I do have a garden. I am privileged and fortunate in that sense.
Okay, so not everybody does. So you may have grown your own vegetables or herbs or something, may you not?
Yeah. In lockdown, yes, absolutely. Yeah, I would like to think I still did, but I don't.
Okay, so, I'll just say, let's take an example of one of those troughs that you fill with soil and you plant a row of rocket, which is a weed, basically. As an Italian once told me when I was saying, how do you grow rocket? He said, it's a weed. So it's not difficult to grow rocket. You can't go wrong. If you throw it on the soil, it will grow. And you taste that rocket. I'm saying this because it's fresh in my mind from an experience a few weeks ago. Taste that rocket, compare it to a bag of Sainsbury's or any supermarket, other supermarkets are available, rocket, and they are completely different beasts. They just don't taste the same. Now, I'm not saying that supermarket rocket is badly, grown or whatever, but it's probably not as fresh and it probably has been gassed in the bag because that keeps it fresh. And so I don't know how that affects what we're eating from various sources, but I'm sure it does. So as long as you eat as well as you can from as many different things as you can, that's the best you can do. And to get into specific sort of nutrients, that's where it becomes. The only time I do that is if I've done testing on somebody and I can see they're deficient in these 4 things, and that's important because of their genetic setup, because they need those cofactors to make dopamine, and then I will say you need to have some minerals and blah. And I'm often find myself saying to patients who say, should I take a B complex? I'd say, well, I wouldn't waste your money because I don't know whether you need a B complex and I don't know which B vitamins you might need. Until I've done a test, I can't tell you, and it's not targeted. If you want to add to the profits of the health food shop that you're going to buy it from, great. It's not going to do you any harm, but I don't know if it's going to help.
Well, let's come back to that testing then and just touch on, pick back up on what you were saying about cortisol. So what about the nervous system then? Because this is something that I'm really interested in. How does that play a part in this whole picture, this whole person approach? And I guess, again, how do you determine that?
Well, it's complicated, but I mean, when I was a young thrusting researcher in about 1842, I did some research around depression and physical symptoms. And in those days, the cortisol test was very much lauded as a possible explanation of depression. Dips in cortisol were the thing. And it turned out that this didn't really work because, like all simplistic ideas, they don't, because there's no one explanation for everything. A bit like there's no one explanation for ADHD. ADHD is not just due to some kind of problem with dopamine. Okay, let's get that straight. But a lot of people talk about that, and that's what the drugs do. So cortisol it fell into abeyance. And now it's still not really terribly well regarded by the mainstream medical establishment. But I have learned that through salivary testing of cortisol, which is really easy to do. You just spit in a tube and you do it 4 times in a day. And then you've got a 24-hour profile of, 16, 18-hour profile of what your cortisol is doing over that time. Can be very informative. But like all things, it's not just the silver bullet. If you see someone who's got a raised cortisol evenly across 24 hours, I tend to think these days, well, that person is very on edge. They're what I call neurologically upregulated, and they're unlikely to be functioning optimally, particularly if it's very high. And if it's a bit high, it's not a problem. If I see spikes, then depending on what I know about what was going on at the time, I would say that they might be very reactive. So these are the people who... these are the children who might well be more prone to meltdowns, for example, because they spike under stress very easily. And then I see another group where there's another 2 groups. There's a group where they're not too bad in the day and then they go up at night. So they're the ones who can't go to sleep because cortisol is your alert hormone. It keeps you on alert along with adrenaline, ready for stress and threat and danger. So if that's high at night, you're not going to settle. And then I see another group where it's flat. And they've dropped. Often in the morning, it's very low. And those are the ones who are really almost at the end of their capacity. Their petrol tanks have run out and they're really, in another term, adrenally exhausted. So then you're thinking about adrenal support. Now, adrenal and cortisol stuff, it's just not really kosher in mainstream, but it's just kind of common sense.
Because I guess it powers, as you said, or... if powers isn't the right word, it's almost like a control system for how we're managing and coping day to day.
It's our coping hormone. It's the thing that keeps us going in the face of stress. And it's really useful in the right amounts. In fact, you're dead without it. You have Addison's. But it's got to be there in the right amounts at the right time, stimulated by the right things. So that's interesting, but it's not enough on its own. Then the question is, well, why? Why is this profile looking like this? Is it because, as is often the case, they're rather deficient in some of the things like magnesium, and we know that magnesium is a real problem in diets. Most of the magnesium has now been leached out of our soils post-war. I think magnesium's dropped anywhere between 40 and 60% in the soils compared to where it was pre-war, and it's to do with intensive farming. So that the stuff that we eat doesn't always contain enough for our needs, and magnesium is generally very calming and helpful. So that's why you see all these magnesium supplements all over the place being peddled. And sometimes they're very useful, and sometimes they're not. They just make you loose in the toilet, and that's not useful. So, so you have to be careful and understand what you're doing. But I would never tell people not to try things because I'm a great believer in trial and error and also suck it and see.
Yeah, absolutely, which I think ADHD in general needs that approach, doesn't it, across many different factors. So when you're determining that then with a family, and we touched on testing, so family comes to you, first of all, how do you decide which interventions, whether that's lifestyle changes, supplements, medication where necessary, become part of their care plan?
So this is a bit of a dilemma for me currently, Claire, I have to tell you. So for the last few years, my approach would undoubtedly have been take a very careful history. I'm very interested in things like gut health, sleep, as we've discussed, early history in terms of illnesses and vulnerabilities. That tells me about immunity. Family history can be highly relevant, as you know. These kinds of problems tend to run in families. They don't always, but they can. So I'm very interested in the history, and that gives me clues where to go. I often will do a cortisol, but I don't always, and that's the spit tests. And I may do quite a comprehensive urine screen to look at nutritional and metabolic functioning and adequacy. And that's great because it gives me a lot of pieces of the jigsaw, as I call it, to think about and put together. And then I can come back to people and say, well, look, this is what we've got. This is what you're presenting. It probably makes sense to do this, this, and this to support those bits. And at the same time, we might want to try some medication, and that's the integrative bit. We might well want to try some medication, either while these things are coming on board and supporting you, or because it's too slow, because it's more gentle that way, and you want to get on with it. And sometimes combining those things is extremely helpful, and that's what I aim for. In fact, I was just reviewing this morning a patient who I saw quite a few years ago now, actually. And when he came to me, he had ADHD and probably ASD level 1, and did some testing on it. He was very low on lithium and a number of other things in his setup, and he had ADHD symptoms, and we ended up, and he had quite a lot of toxins in his hair as well. So we did quite a lot of work on detoxifying him, getting his minerals in balance, and giving him medication. And at the time, he responded after a year. It takes a year to get these things right. He responded very well. And I thought at the end of it, well, as I often do, was that the supplements or was that the medication? We'll never know because we did both, and that's the dilemma. But, he's now a big lad and he's on a very low dose of stimulants. And I'm convinced that he'd be on a much higher dose of stimulants if we hadn't treated all his vulnerabilities.
It's very interesting because actually that was going to be my next question, and that feeds perfectly into what you were just saying then. It's about how do you get that balance between the kind of conventional and the more alternative approaches in that sense. I think that's a really interesting point, that actually what you're saying is it's impossible to unpick it, but the fact that the approach that you took included both conventional from a medication perspective and all of the other elements from, I'm assuming, like supplementation and things like that, have really balanced his symptoms out to mean that, in your view, actually, for his size, he's on a reasonably low dose compared to what you would expect.
He's on 20 milligrams of methylphenidate, which is like nothing for his age.
How old is he, if you don't mind me asking?
I think he's about 15 now.
Okay, yeah. It's really interesting because I guess that's the goal in all of this, isn't it? We're trying to manage symptoms, we're trying to improve quality of life, but all of that is, and I have to say this as a parent, so carefully balanced with the side effects too. So you're trying to do everything you can to get that balance and get the right outcomes for our children, for the environments that they're managing in, I guess. And that might be different at school compared to at home, or, at weekends when they're playing sport. And how do we create that picture? So for those that are using medication, then, because you gave that example then, and, I have 2 children with ADHD. My son takes medication, obviously, with supplements and balanced out that way too, but my daughter doesn't. So I have that kind of dual picture, if you like. And for those that are using medication, what difference can adding in those lifestyle changes? So let's say they're coming to you, perhaps already diagnosed, already taking stimulant medication. What difference can then adding those lifestyle changes, those interventions in afterwards make? Because I guess then you can see those differences, can't you?
Okay, well, that's a very interesting question and quite difficult to answer because I don't know is the answer, the honest answer. So I continue to work around that if people want. Now, those people are the minority because usually, let's face it, stimulants are powerful drugs, but they're also magic. For some kids, they are transformative. So I would never throw, as I call it, the stimulant baby out with the bathwater because they're very useful. It's sad, but true. I'd rather not have to prescribe stimulants to anybody, but I'm a realist. And I've seen people's lives turn around with them. So I'm not going to throw them out, but I'm going to try and minimize their use and see how we can, do it sensibly, because as you rightly point out, side effects are a real issue. I don't have a lot of people with side effects, but I do have quite a few, and that can be limiting. Particularly the sleep and appetite stuff can be a real problem with stimulants. That's a real problem. So if they're already diagnosed, so first of all, they often don't come because they've got an answer. All right. So, thank God, methylphenidate, it's really helped our kid, and that's the answer. So why would they come and see me and spend a load of money seeing somebody else when actually it's all right? And so if they do come, it would probably be either because they have a a kind of not a moral, but a sort of worldview conviction about the importance of looking at the whole person, and may already be aware of the influence of things like diet in their own lives, or the drugs aren't working properly or enough, or they've got problems with it. So those are a minority. And the answer to that is, I think what happens that can help is that if you get the metabolic stuff right and the lifestyle stuff right, the need for drugs decreases commensurately. It doesn't disappear. But as I've just said in that example, you may end up on a much lower dose and therefore have much more manageable side effect profile than if you didn't do that. Now, that's not a guarantee. It's a hope, an aspiration, but I have seen that happen, I think. It's quite hard to be sure because it's not a scientific controlled experiment.
Yeah, as you said, it's the suck it and see trial and error.
It is a bit like that. But I wanted to come back to your point about that I made earlier about now. So I said in the past I would have done this. I think what's happening now is that we are in a, let's face it, financial mess as a country and an economy, and people have less money to throw around, and I completely understand that. I'm extremely sympathetic to it. And testing is not cheap. It's not horrendous, but it's, as you know from your experience, it's something you've got to commit to. It's not like £5. And so a number of people will come now and say, we're very interested in your approach, Dr. Fry, but we don't really want to spend a lot of money on tests. So then I have to cut my cloth according to what they can afford, which isn't easy and isn't always satisfactory, because if you miss, as I say, when I talk to people, if you're missing a piece of the jigsaw, it's quite hard to make sense of the picture. And so I have to really use my clinical acumen to know what might possibly help. And that's a challenge these days.
So how do you approach that? Or is it not that simple?
Heart in mouth.
Yeah. Because as you said then, it's the jigsaw.
It's hard. And sometimes people can do it over a period. They can, save up and do some of the testing as they can do it. And as they go forward, sometimes they see the benefits and then they're able to commit to a wider look. I'm still finding my way through that particular jungle because it does seem to be a relatively recent thing that we've noticed in the last year or so.
Yeah, that requires you then to have a completely different approach to being able to treat.
Well, it's not completely different, but it is definitely modified. And I think what's happening is because of the mushrooming. I mean, there's an explosion of services that will give you an ADHD diagnosis now online. And some of them do prescribe, a lot of them don't. They send you somewhere else to get your medicines. And then you're into it's helping him 70%. That'll do.
Well, I'm with you on that in the sense of, and as you said, medication can be absolutely life-changing, and it's absolutely had that impact for my son over the time that he's been using it. But even then, I would say to me, that's not enough, that it has to be this kind of whole picture, because you used a term earlier on in our conversation, which was the kind of buckets element, and you can name the bucket whichever way you want. But often that bucket has lots of different factors with lots of different labels coming into the jigsaw puzzle, as you described it. So I'm just wondering how those overlapping, co-occurring jigsaw pieces like anxiety or autism or PDA traits alongside ADHD might impact your approach.
So that's a very, very interesting and intriguing question. And that's sort of what I spend most of my days doing, talking to people about. So you've just named 4 buckets: ADHD bucket, ASD bucket, anxiety bucket, and PDA, although that's probably a little bucket inside autism. And my interest, as I said earlier, is not which bucket you're in, but what gets you into those buckets, and therefore how you might get out. And those buckets don't really help because they do overlap into one big pool. I'm getting lost in the metaphor. But, all those things for me are very often present, not so much the PDA, but I definitely see ASD type features, ADHD type features, and key anxiety features all mixed up together and swirling around. And then, I often have a question, which I will debate to some extent with families about, well, what do you want to do first? Do we look at the anxiety? Is that what's driving? This is usually in females. Is that what's driving difficulties in the school environment and therefore concentration? Or do we look at the other bucket, which was called ADHD? Or do we look at the social communication difficulties that she's obviously having because she can't keep up in her social interactions very well and gets very anxious about that, which drives the anxiety? called the ASD bucket. And that's why the buckets become very unhelpful, because for me, it's more about what's the picture that's actually putting this all together into one set of problems, one problem, if you like, one presentation.
Yeah, because it is overlapping, isn't it? I think that's what we're seeing so much more and more, that often these things, they can, but they often don't exist in that really siloed sense, that we're looking at a much more kind of bigger dimension here. What about anything else other than obviously the things I've mentioned? So you talked about earlier on the family history that you're taking into consideration, maybe that child's own medical history. When you're doing that, where time allows, finances depending on the approach, as I appreciate you mentioned that is a massive challenge, what other bits are you looking out for in that big picture? Like, are there things that are particularly interesting to you, or that you perhaps see as patterns?
I'm very interested in autoimmune histories in families. So by autoimmune, I mean things like rheumatoid, gut problems, pancreas problems, including diabetes, thyroid. There's just some examples, but I routinely inquire about those. Why I'm interested in those? Because if there is a sort of predisposition to those kinds of things in families, that may well have an influence on the child's presentation, in the sense that we increasingly realize that lots of mental health presentations are manifestations of both inflammation, which is part of the immune process, and auto, i.e. self-directed immunity. And so depression is increasingly now seen in all ages as an inflammatory condition. It's not just to do with serotonin. Of course it isn't. And of course, you might cynically say that some of the drug companies have jumped on that bandwagon and claim that their antidepressants are anti-inflammatories. Well, interesting, but not yet proven. So I want to know about those histories. I'm particularly interested if those are histories on both sides of the family. And, genes are important. They're not your fate. They are your template that you have, but they can be terribly important. And the future is undoubtedly individualized genetic medicine in all areas. And this is another example.
That's really exciting, I think, that future. I liked what you just said there, that genes are your template, not your fate. I love that. So what does that mean? Tell me a little bit more by what you mean by that.
Well, it means you may have, so the classic example I give people when I talk about this is I show them a picture of the serotonin pathway. On the first step on that serotonin pathway from bananas, i.e. tryptophan, which is in bananas, chickens, avocados, nuts, turkey, amongst other things. The first step on that is a step to make something called 5-HTP, and the next step is to make serotonin. And the first step, that top step, amongst other things, needs vitamin D. And so you go along to your doctor and if you're lucky, you get a vitamin D test, or you do one online, and says normal range 50 to 100 or whatever, and you're 53, and you go, thank God for that, it's good. Except on that step is also the VDR gene, the vitamin D receptor gene. And the testing I do looks at your sensitivity to vitamin D through that gene. So a result that is a normal population result would mean that you're right, 53 is a good level to have, you're okay. But if you're very different to that average setup, you may be much less sensitive to vitamin D. So for you, 53 is not enough. You may need 100. And unless you know that that gene is there and its sensitivity, you can't possibly know that you need more vitamin D than 53. There's no way to tell. So that's why I see it as a template. But that person is probably going to be all right if they live in this country with sun and eating a reasonable diet. If they go to Norway for 6 months in the winter where there's no sun and they don't eat oily fish, which is good source, they will drop that step. They won't make enough 5-HTP, they won't make enough serotonin, and they will get depressed. And at the bottom of that is melatonin, and they won't sleep. And that's because their VDR gene is less sensitive, makes them less sensitive to vitamin D. So it's a template, but it's not inevitable they're going to have a problem, because the template is how you interact with your world.
So fascinating, isn't it? It really is. And I think that's why these steps towards personalised health and personalised medication plans, if that's the right term for it, is so interesting and so exciting to me, because it feels like when we start to understand these, I was going to say simple, it's not simple, is it? But actually, when we can have that picture, quite simple changes potentially can have a very, very significant effect. And I guess then when we take a step back and we think about that ADHD picture, and I know we've touched on medication, those cases whereby, and we know that it works very successfully for many, many, and then for some people that it doesn't. So it almost then begs the question, what's going on for those individuals? And I think as far as we know, we don't have that evidence and those answers yet. But I do think it's very interesting and a really exciting path that comes with it. So I wanted to ask you just on the jigsaw piece puzzle there, where we were talking about anything else you might be looking for, just one element that I found interesting in the conversations that we've had, and that was around strep. And I just thought it would be a good opportunity to bring it in because it's something that I'd never even considered or heard of as relevant, for want of better words. You and I had our conversations, and the links from there to pandas, which is something I only know very, very little about, but again, something I didn't see as part of that picture. And I just wondered whether you might be able to tell us a little bit more about that if you think it's relevant to our conversation.
Yeah, so I think this is a huge area and still relatively ill understood. Well, let me tell you a story. So I saw a patient many years ago now, and that patient was a young boy of about 11, something like that. And the parents came with him and they said, he was perfectly normal, and then 3 months ago, he became hugely anxious and started having OCD symptoms, and he wouldn't go to school, and he lost his appetite, and it's just, it's incredible. I said, well, did anything happen before that? I said, well, he had a sore throat. Anyway, long story short, this boy had pediatric autoimmune neurological syndrome, which is PANS, and used to be called, in collaboration with PANDAS, which was the same, but with strep at the end. And I knew very little about it then. And I asked around, and I was told that there was this thing that some people believed in and some people didn't. And one way of treating it was to give antibiotics because it was due to strep. Anyway, I researched this and thought about it a great deal and realized that at that time, you could basically be struck off as a doctor for treating this mythical condition because there wasn't, quotes, enough evidence, close quotes, to support such an approach. So I was naturally rather concerned about that and chose to step back from that particular issue for the time being while I thought about what to do. And the issue is that it's very straightforward, that there is no doubt this thing exists. There's no question about it. And it's very similar to something called Sydenham's chorea, which is basically to do with basal ganglia in your brain being messed up. And but long story short, basically strep attack, the antibodies from strep that you make for your sore throat attack your basal ganglia and they cause problems. And they cause typically exactly those symptoms: OCD, marked anxiety, separation anxiety, decrease in appetite, and total meltdown, basically. So I took my heart in my hands and treated him, and he got better. And I thought, oh my God.
Wow.
And I was converted. I gave him antibiotics. And so writ large in front of me was clear evidence that infective causes cause psychiatric problems. Now, we just don't know how much of that is true across lots of conditions. But I've already told you about autoimmunity and inflammation being relatively important in all sorts of presentations. So it's not a big step to go from infective inflammatory conditions, because that's what infection provokes. Inflammation is a normal response. It's good in small amounts and not in big amounts. It's not a big step to go from autoimmunity being a problem to bugs causing a problem. The problem now, several years down the line, I think we're probably about maybe more than 10 years on from that, is that we now realize that it's not just streptococcus bugs that cause this problem. In fact, it's much wider. And so now big in the sort of panorama of this is Lyme disease, mycoplasma, Epstein-Barr, lots of things are out there. Instead of being due to strep, it's due to many microorganisms. And that opens up a whole sort of nightmarish area of what the hell you do about that, how you test for it, what you look for, what are the presentations. And I think that, a number of my colleagues, certainly I would say that I have seen subacute presentations of PANS, PANDAS, whatever you want to call it, where it's clear that in the history, the child had, for example, lots of sore throats growing up, had lots of antibiotics, or had a lot of ear problems needing antibiotics, and that sometimes the bugs that cause that are still hiding somewhere in the body, often sinuses where they're relatively inaccessible to antibiotics, sometimes other what they call privileged organs or materials, which are sort of don't have big blood supplies, so they're difficult to get to. And this stuff drives problems. So I am always interested in the early history of illness, and that combined with, a vulnerable autoimmune profile in the family is very strongly suggestive of thinking about what else might be worth thinking about. What you do about it is much more complicated these days. You can't just giving antibiotics usually doesn't work anymore because we're not dealing with just strep. Pause. That said, when I do some of the testing I do, particularly on stool specimens, I sometimes see a lot of streps piling up in the gut. And then I think, maybe that's not so helpful. And so I will think about what to do to put that right. It probably won't be antibiotics because that doesn't work. And it doesn't help your gut anyway to give antibiotics for obvious reasons. It wipes everything out. So it's a tricky one, but I'm interested in it.
Yeah, I think it's very interesting. And thank you for sharing that, because I think it is definitely something that is lesser known and lesser understood. So it's great to be able to shed some light on it. And I think it's true in that holistic sense. It comes right back round to the gut health element of it and the impact of antibiotics from that perspective, as you said. So for parents who are listening, and perhaps not on this integrative, holistic, whole person pathway for their children, what steps can they take right now to help support their child in that whole person ways that help them thrive beyond, say, just medication if they're medicated or if they're not medicated, without, obviously, there's a beginning step to this. I appreciate would be then coming to see somebody like you and do that testing. But what steps can they take at home to start that process?
Look at diet, look at sleep, look at social media. Those are probably the first three. And social media is a real problem and a real stress. And I don't have an answer to it any more than anyone else, but I know it needs thinking about urgently, particularly for girls, because I think it's a blessing and a devil. So those are the first things that I would do. I have no interest financially in Lucinda Miller's book, even though I wrote a foreword for it, but I would strongly recommend it as a good way of working out where you might go with diet.
Yeah. It's useful. And as you say, Lucinda has lots of pointers in there, places to start, and the science behind all of the things she talks about in there too, which I think is really useful for people.
I think, the one thing you can do, so if your child has a very limited diet, introduce one new food a month, preferably something healthy, and don't make it too challenging, make it manageable. And I think lots of parents I talk to, and Lucinda will also agree with this to some extent, we'll hide vegetables in bolognese sauce or whatever it might be, smuggle them in. And that's fine. But I think it's quite good to be upfront about what you're doing. So you can start to engage your child and having a conversation about why you're feeding them this stuff. Because what you've got to do with your child is prepare them for life. And if they've got this vulnerability, they're going to have to manage it as an adult themselves. So it's never too soon to start thinking about what am I going to do about this? And it's not easy. And the other thing is carb substitution. So carbs are basically what fuel children and particularly adolescents. They love carbs. And carbs are great, but add fat and protein to that. And sometimes if you can swing away gently from carbs towards substitutes, the classic one is, I'm afraid, a terribly middle-class proposal, which is, substituting quinoa for rice. Well, that's fine if you can afford it and if we can do it. But I mean, just have a think about what you can do instead of always just resorting to pasta.
Yeah, I'm so with you on that in terms of being upfront about it, because my logic has been, even if I'm getting the kind of teenage eye rolls now and the pushback, it's laying the foundations to at least understanding why, so that one day that stuff clicks, or, as you said, you add one thing in at a time. I've actually found that really successful. My son he has a really balanced diet, but he's very particular about what he eats, which is not uncommon I'm sure many people listening have experienced that same thing. And I found that to be really effective, that, just changing, or not even changing is not the right word, trying to add in one new thing at a time, however long that takes, until he's comfortable with that before going any further. Whereas before, I think I would have tried to be doing many, many different things at once. And then you get so much pushback. But the thing that you said about carbs then is so true with the fat and the protein. Like if he's at school and I said, what have you had for lunch today? And then I'll always follow it up with, try adding in some cheese, or what protein have you had with that? And he kind of rolls his eyes at me. But I know that it's laying those seeds, it's laying the foundation, so that slowly he's starting to think about that picture for himself. Because you're right, like that's the thing. It's not just how we help support them as children, but it's how we help them take those steps towards independence when they're trying to look after themselves in the best way possible as they get older too.
And I think fish is a particular bugbear. I mean, your mum always told you eat fish, it's good for your brain. Turns out she was right, of course. Well, some fish, not tuna. And the thing about fish is that lots of kids don't like fish, but that's one which you can sort of hide in things, and even you persuade most children to try some form of salmon dish for you to stir fry or something else. And you can always hide anchovies in sauces because they melt and disappear into nothing. And anchovies are actually really good because they're oily. It's oily fish we're interested in, not white fish, really. Nothing wrong with white fish, but it's not full of omegas in the same way that oily fish is.
So in addition to hiding and smuggling in anchovies and sauces, what one final piece of advice would you like to leave parents listening to this to help them feel less alone on this journey and to help them support their children in a much more whole person way?
Enjoy your child.
Why do you say that?
Well, because this whole conversation has been about the child as a problem. And actually, I'm sure parents do enjoy their children, but, sometimes it's just a bit much. But, gratitude journaling is probably a really good thing to do. I don't do it, so I'm talking out of my proverbial. But I think being grateful for the good things that you see in your day and your child as part of that day is probably not a bad thing to do. So I think the given thing is you're supposed to write 3 good things down each day about what's gone well that day at night.
I think enjoying your child is a really lovely piece of advice to sort of end on. One, because as you say, it takes a really positive approach. But I think when I think about this conversation, I don't see it as a child being the problem, but I see it as the way that the picture presents the problems. And I think the really nice way of that is it's sort of trying to say, well, let's step outside it, because even with all these challenges and all the things we're trying to do, we are trying to help the whole person, because we all love our children, don't we? And someone once said to me, and I thought it was such a great way of looking at it, was a child psychologist, and they were saying, be careful not to let those moments that happen, the challenges in the day, ruin everything else that happened around it. There's that. It's almost like you can hear your own parents in your head from when you were younger, like, oh, you've ruined it now. It's not, when one thing happens, it's not ruining the whole thing. And that was really great advice for me, to be able to go, we are going to have these bumps in the road, multiple bumps every single day, but to try to be able to not let that take away from all the positives that come alongside it. So I think saying enjoy your child is a really lovely way to finish. So thank you very much.
Okay. It's been a pleasure. Thank you for talking. It's lovely.
Thank you for joining me. If you'd like to learn more about Dr. Richard's work, then please do check out our show notes below for more information. Or if you'd like to find out about how I can help support you and your children with personalised ADHD coaching, then please do head to allaboardadhd.com. You can also find me on Instagram and TikTok at All Aboard ADHD. Most importantly, if you enjoyed this episode and found it helpful, please can you follow and review All Aboard wherever you're listening today, to help other parents find this podcast and welcome them aboard our journey too. Thank you for listening to All Aboard ADHD.